Effective communication actually is a set of domains, I think of them as domains, that are supporting communication efforts. So it's not just about speaking and listening when we communicate. It's actually about a whole host of cognitive processes like attention and memory. I mean, I challenge you, if you have problems with memory, to tell a really good joke.
Welcome to Some Stutter Law, a podcast by the Communication Collaborative. Some Stutter Law is Newfoundland and Labrador's first podcast about living with communication disorders. We speak directly to people living with speech and language disorders and others such as speech-language pathologists, researchers, educators, and family members. We use inclusive language and themes to help rebuild confidence and hope by dismantling myths, stigma, stereotypes, and barriers. My name is Greg O'Grady, and I'm a person who stutters and a co-host of Some Stutter Law, Newfoundland and Labrador's first podcast about communication disorders, along with my co-hosts.
And my name is Katelyn Mayo. I'm a speech-language pathology student, and I'm Greg's co-host on this podcast.
Some Stutter Law mission is dismantling and rebuilding communication disorders. Let's start listening. Some Stutter Law mandate is in the spirit of Newfoundland and Labrador's humor, robust and frank interactive discussion. Some Stutter Law podcast aims to rebuild confidence and hope for people who live with communication disorders by dismantling myths, stigma, stereotypes, and barriers.
The objectives of Some Stutter Law podcast are raising awareness, education, understanding, and acceptance of communication disorders by providing support, current information, research, and resources. Acknowledging that communication disorders are a quality of life issue. Throughout life, communication challenges can impact a person's life emotionally, educationally, physically, socially, and vocationally. Some Stutter Law podcast is committed to creating a safe space where guests can be themselves without fear of being judged.
Today, Some Stutter Law welcomes Penny Welch-West. Penny is a medical speech-language pathologist working at Parkwood Institute, St. Joseph's Healthcare in London, Ontario. She holds a lecture position with the University of Western Ontario and an Adjunct Clinical Professor position with McMaster University. At Western, she has taught in several courses over the years, including acquired language disorders, clinical applications, augmentative and alternative communication, traumatic brain injury. Penny practices as a medical SLP in a hospital setting working in complex and continuing care, as well as acquired brain injury working with an adult population, including young adults. She has a special interest in concussion care and specifically return to learn in the secondary and post-secondary school populations. Penny serves on many committees where she advocates for the role of speech-language pathologists in provincial and international guidelines, quality standards, research initiatives, and position statements in brain injury. Throughout her clinical practice, she can most often be found advocating for cognitive communication services. Penny loves historic homes, renovating, and DIYing. She is the proud mom of 4 kiddos who are her biggest technology influencers. She is married to a paramedic just to round out the work in the healthcare field. Welcome, Penny, to Some Stutter Law.
Yeah, thank you so much.
This is quite the mouthful for someone who stutters.
I thought it was a beautiful thing.
Oh, thank you very much.
It's that was just wonderful,
Well,
actually, to hear that back. And yeah, just when you talk about do-it-yourselfing, I think you like do-it-yourselfing too. This is a tremendous initiative that you guys have brought forward. And I guess my only disappointment is that I didn't know about it just a bit sooner. But I do know now, and I'm excited actually to do this tonight and to share your work. It's really tremendous.
well, Penny, it really surprises me that with after reading your bio, you're a very busy person, and we really appreciate having you on board. I was thinking when I was reading it, uh, does does Penny have time to breathe with all the work you're involved in?
Yeah, I know.
Okay.
I feel fortunate. I feel really blessed to get to do work that I feel is rewarding and makes a contribution and is different every day. No more than during a pandemic have we had to pivot, do things differently, and continue the great work in supporting people with communication differences and challenges. So, yeah, I
Mm,
feel really fortunate to get to do what I do.
mm. Well, thank you again, Penny, for joining us. So both Katelyn and I have a few questions for you, but I'll let Katelyn go first. Seems Katelyn is an aspiring speech-language pathologist. Go ahead, Katelyn.
I mean, I think the best place to start is just kind of your history, how you decided on speech, what made you decide to work in the medical field, kind of what sparked your interest there.
Yeah, sure. I made a few notes so I can keep on track because, yeah, it's a long time ago, it seems. I mean, I've been working now, as a medical speech language pathologist since the beginning of my time. I was so it's been about 23 years that I've been doing that. So I decided to be a speech language pathologist in the old days where the career counselors, and not to put anyone on the spot, but Greg might remember that you would go to guidance and they would present a number of career paths potentially for you. They'd ask you a few questions. In my case, as I started to talk about my interest in sign language and my interest in communication and maybe being a translator, they went to the fax machine. This is still a thing, fax machines, but they're less common. And it was really very common for them to receive job opportunities and guidance for people in all different kinds of ways. And it happened that that day, the guidance counselor that was working with me said, "Oh, I think something came through the fax machine that maybe you'd be interested in." And that's was where he brought back the description of what a speech language pathologist is, what they do. It was identified as a growing profession, and it was expected to have good growth in terms of a career path. And of course, if you're going to spend 7 years, which it was at the time, I know, Katelyn, you're able to do this in 6 years, but it was a preparatory year in addition to the master's when I did it. So if you're going to spend that long training, you want to make sure that the job opportunities prospects are going to be there when you're finished. So I guess I had always worked as a direct care worker. From that point on, I worked with students with special needs, young children, and all of my work was with children. So I worked as this direct care intervener. I worked as a behavioral assistant for the school boards, and I supported young people, young children, with lots of different difficulties that resulted sometimes in behavior, cerebral palsy, apraxia of speech. And I really was the go-between between the therapists, occupational therapy, physiotherapy, and of course, speech language pathologists who would come and see these children for treatment services. And I would implement recommendations for therapy and then work with families to sort of make sure things were consistently done and supporting outings and socialization for these children. And so we did a lot of different things. So my experience up until, I went to grad school was all in really working with children. So I imagine my surprise and my mom's surprise when I had my first clinical placement while I was a grad student in a hospital setting, and that was in head and neck cancer. And so I worked with a speech-language pathologist who's now my colleague. She was my mentor, but was my colleague at the time. And I think when I went into the placement, adults had never really occurred to me. It had not really been on my radar of a population I would that speech pathologists were working with. And it was sort of profound to me that I would meet people. Typically in head and neck, you would meet people prior to surgery. Sometimes that surgery was for oral cancer or a pharyngeal cancer. Sometimes it was for a total laryngectomy. And so this is complete removal of a voice box. And you can imagine, I don't know, just the coming to terms with that reality for individuals I was seeing. And I was a student, and it wasn't lost on me that the fact they were communicating typically on the day I saw them, that the next time I would see them, they would not have that available to them. And it just seemed so important, the work that the speech pathologist was doing to restore communication following, in particular, laryngectomy. So it was my job to help them communicate, and they were literally voiceless. And I think it was profound to me. And I felt like this is my calling. This is what I'm meant to do. So I think that's the spark that I had in working in a medical setting. And we also supported inpatient patients following stroke, and I think a bit of trauma. As you know, or may realize, in a medical setting, there aren't very many of us. So we tend to cross many programs and many disorder areas. So it turned out that variety, I really enjoyed that. And I also really enjoyed the messiness of the work. It's funny to me because my mom just couldn't believe that I was making this shift to work in medicine, and that I was going to work with some of the most complex communication cases. So the messiness of the work we had in serving populations who had tracheostomy. So due to airway, they would have artificial airways and ventilator dependency. And it seemed like the messier it was, the more complicated it was, the more I liked it. And the more I became curious about supporting people through, what could be sort of their worst or most challenging time, and helping them to have hope that we could restore or improve or optimize communication. So I think the complexity of the cases, the working as part of an interdisciplinary team, I loved it. I continue to love it. Turns out I don't really like working on my own very much. I had an opportunity to do that, and it turns out I just love team and love working. So I think I don't have an issue with not knowing. That has really helped me. I don't have the answers to each thing, and I kind of like the complexity of that. It's sort of the thing that feeds me, and the more varied the caseload is, the better I like it.
Amazing. So kind of on that note, we have never had a medical SLP on the show, or anybody kind of working outside of stuttering and like motor speech-ish type stuff. And so if you maybe want to give a very brief, which is very hard, overview of the types of people that you would see on your caseload as a medical SLP.
Yeah, so it is very varied. And I think, where could I start with that question? So I would say medical speech-language pathologists are SLPs who are embedded inside healthcare teams. And so if you have an interest in medicine, which I would say there's a large number of speech-language pathologists who go on and, complete degrees and then go on into medicine. So if you have an interest in sciences and the medicine and communication, you might just sort of naturally find yourself really enjoying working in what is mostly, not always, mostly a hospital setting. And I should say, I'm only speaking from my own experience as a medical SLP. There are many, many more of us in the States and probably in other places in the world. But most people, I think, when they enter into speech, are thinking about pediatrics, and they're probably thinking about school boards, which is amazing work in and of itself. So the types of patients I would see in terms of caseload, it really varies as a function of which program you're in. So I work in a medically complex unit, but you could find medical speech language pathologists working in very specific areas like stroke or brain injury. Speaking from my own experience, I work in this medical complex unit, which is a place where people who have all of those different disorders would come, but they usually need the services or the expertise or the lens of all kinds of professionals. So I might see a patient following stroke, but you probably would end up in the stroke program and not in my program if it was fairly, and I hate to say that because it seems not right, but straightforward. People I would see would have all kinds of other challenges, perhaps a tracheostomy, problems with dysphagia, problems with consciousness, and maybe other medical complexities associated with the type of stroke they had. So I work with those who have dysphagia, which is swallowing disorders. I work with those following stroke, those following brain injury, including aneurysms. I work to support individuals who are regionally coming to our program because we have expertise in supporting those who have ventilation needs and also tracheostomies. So this may include working in augmentative communication, alternative and augmentative communication, essentially putting communication in front of people that is alternative or replaces typical communication. So we can think about high-end technology and sort of low-end technology and everything in between. In my program, we also work with progressive and degenerative conditions. So if we think about ALS or multiple sclerosis, Huntington's disease, dementia, we would also see those individuals within my caseload. So we're kind of getting the picture of the complexity and the variability. A lot of the patients I see have cognitive communication difficulties, and you talked about motor speech and stuttering, which I don't see a lot of individuals who have stuttering, sometimes acquired, but not often. But we definitely see a lot of cognitive communication problems. And so that's quite different than working in motor speech a lot. But we would see motor speech as well, so dysarthria. We have lots of reasons why people have cognitive communication challenges, and it's not always so straightforward. If we think about people post-stroke or post-brain injury, we might expect those individuals to have troubles with attention and memory and reasoning skills. But we also see people who've had long stays in hospital. I mean, we're in a pandemic and people have been hospitalized for long periods of time with less stimulation, from visitors, family, friends who used to be at the bedsides. And it's the loss, I think, of some of that connectivity that contributes to further medical complications of people just being disconnected and struggling to keep track of time and be aware in ways. So if you're already compromised and then you don't have stimulation, right, you can suffer further effects. It's not just people think about walking. Well, if you don't move the body and patients aren't moving and walking, they lose that ability. They become weak. Something similar can happen to our cognition and our ability to communicate effectively when we're starved for that. So we see people following deconditioning, which is that stuff, post-operative fog, if you have anesthetic and that sort of thing, post-surgery. And I work in palliative care as well. So it's and I would be remiss if I did not mention that we do have some post-COVID cases as well. So I don't work on a program in my medical speech-language pathology practice that's really defined, but there are other speech pathologists working in medicine who have this sort of more, what's the word, homogeneous grouping of patients that are all post-stroke or all post-brain injury.
I was wondering if you maybe wanted to speak a little bit, just because we'll probably have some listeners who don't know about what exactly cognitive communication is. I know what it is because I just did an assignment for you all about it, but maybe you want to explain that to anybody who's listening.
Sure. That's a great question. So cognitive communication actually is a set of domains. I think of them as domains that are supporting communication efforts. So it's not just about speaking and listening when we communicate. It's actually about a whole host of cognitive processes like attention and memory. I mean, I challenge you, if you have problems with memory, to tell a really good joke. It's going to be, I'm not a good joke teller, and I think my memory is okay, but it's going to be extra hard for you, right, to do that if you can't remember. So attention and memory and reasoning and problem solving, your ability to think about things from different perspectives. It also includes something we call executive function, which are a lot of skills and abilities that keep us able to plan and organize. For example, today when I was coming onto this podcast, I had to plan and organize my way to make sure I left the hospital on time. That when I got home, I took care of supper for other people that live with me. And then I would have to come on at the right time and make sure that I had responded to the email to download the new platform you guys are using. And so all of that is a lot of executive sequencing and planning. Executive function allows us to predict or see consequences to our own behavior and to sort of be able to not have to live through something that might be negative for us and not understand that there's a consequence to the decisions we make. Cognitive communication are also all of those things around processing speed, so auditory comprehension, our ability to find our words and express our thoughts and ideas, and reading and writing skills, which are communication domains. And I'm missing social communication. So our ability to work with others, to understand turn taking, how much to say, how much not to say, our ability to drop a filter down and not say everything that comes to our mind, and our ability to sort of be able to read others and interpret the kind of intentions of others. So, so all of those, I think, cognitive communication is, when I explain it, people go, oh yeah, how could you possibly return to school or return to life or return to work if you're struggling in those areas? But a lot of times people, patients, clients don't make their way to a clinician like myself or a speech-language pathologist who does that work. And so sometimes when people do arrive finally, as they struggle to, connect to things that they enjoy or things related to work or school, they get emotional. Because they realize that that's the thing that's been missing, that they have never maybe been asked about, why are things so difficult? And let's take it apart and figure out if it's attention that is giving you trouble or your memory is giving you trouble. And you can have a problem in one domain or several domains. And I find that work very interesting and sort of underappreciated by other disciplines, to the extent to which our scope of practice encompasses all of those things. Did I do a good job, Katelyn, explaining that? Because I feel like, yes, you did an assignment. And if I was really quick, I would have said, what do you think, Katelyn, about those areas?
I'm glad you didn't, because I'm on reading week and my brain is turned off.
Right. Fair. That's fair. That's fair. Yeah. And I think I just forgot to mention about one of my passion areas is disorders of consciousness. And when we think about disorders of consciousness, people who are not responding to us, it really comes across all of these cognitive communication domains, right? Maybe they're not alert. We don't know what their auditory processing is like and comprehension. They may not be speaking, often aren't speaking. It's all of these different processes that allow us to do the amazing work that we do. Our brains are incredibly amazing. Social computers.
Penny, I'm wondering now that you see, as you know, this is our first time having a medical speech language pathologist on some sort of law. Now, does the medical speech pathologist, do you have a say in what patients you're assigned to, or how are your cases divided up, and is there a number, or is there like a quota?
There's too many. I'll tell you that. I don't know what to say. This is a really good question. So some disciplines have a blanket referral, and they would see every patient. So on my unit, I have 2 units plus palliative care. So this is like just shy of 100 beds. So it would be impossible for me with my current FTE, which is my full-time equivalence. The amount you're working, I'm working in 0.5 or half time in this program. It'd be hard to really see all of the patients. So we do not have a blanket referral on every patient, but I would say that sometimes I'll go in for one thing, like swallowing. And as I'm in there, I start to realize that this person is complaining of other challenges, almost often with memory, I'd say, that I think I can help them. So we have to work really closely with the other team members. So your occupational therapist, your physiotherapist, social workers, respiratory therapists, to really find these individuals. And if I'm really being, clear about it, we really are advocating for people who are quite vulnerable, who may not be seen, who may be less able to self-advocate and ask for the services that they would benefit from and would require. And so there is a lot of reliance I have on, and I've been working with this team for over 20 years, reliance on the team to sort of help me to identify individuals who would benefit, but more importantly, find individuals who may be at one stage, like thinking again about disorders of consciousness, who may be emerging and who may be really good candidates for more intensity in service. So I don't see all of the patients, although I would be probably very biased and say most of the patients could benefit from at least a check. I mean, just today, there was a person who I was asked to see last week by the physician. And the patient said to me, I really think my memory is slipping. It's going, And so I had gone in to do the assessment thinking she is probably right. She's probably accurate. And when we did the assessment, her results were coming out fairly within the average range. So I went to counsel her today, and she was very nervous, and she kept trying to find me to ask me when we were going to talk about the results. And it was really about reassurance. It was really about, this is actually falling into the average range for your age. And so, rest assured, it's something you want to keep providing your own stimulation and doing strategies and doing different things that can help you to stay healthy. But she was really encouraged by that. I think she was almost emotional that, things were okay. So you do rely on a team and really the physician referral. So how that happens for speech pathology is the physician would refer for whatever area. It could be for swallowing or dysphagia. could be for cognitive communication, could be for voice, any number of things. So the referrals definitely in a healthcare setting, which is different than working in private practice, because of the Hospital Act. We require referral from a physician.
Penny, how many medical speech-language pathologists are in St. Joseph Healthcare where you work? How many is on staff?
Yeah, so 13 of us.
13.
About 13. We did have one audiologist who was full-time as well, but there have been some changes to that structure. I think we advocated really hard for keeping that service, but 13 of us, which in any one place is quite a number, to be honest with you. I was trying to look up because I thought there might be a question about how many medical speech-language pathologists are there in Ontario or Canada.
That's one of my questions.
Is it coming? Okay, so I was like looking it up. Do you know I can't find it? I do have some old data in my mind, which was I knew when I graduated and I wanted to work with adults that 20%, I think it was all like 17% of all speech-language pathologists work in adults. So most people work in pediatrics. So that's a small subset. And then of the 17 to 20%, a smaller subset of those would work in a hospital, so in a medical setting. So, but that's old data. I didn't find anything new. So I'm hoping that's changed and that there are more. But there are 13 where I work.
See, does St. Joseph's Healthcare work in partnership with long-term care? Meaning, would they, if a long-term care facility would ask for a speech-language pathologist to come into a long-term care facility? Now, the reason why I'm asking, before I retired, I worked for 30 odd years in healthcare, and so I worked for the City of Toronto Long-Term Care Homes and Services. So part of my portfolio was rehabilitation, and I had like one part-time physiotherapist, one part-time occupational therapist, 2 full-time rehab assistants, and so unfortunately, you see, back then, there was a lot of.
Don't say it, Greg. Don't say it.
But anyhow, so we were so short, and the whole target population for the homes of the aged. We have 10 homes, and so I worked in 4 of the homes. And so as a manager, I really felt challenged, and I really felt bad for my OT/PT. And then when there was a need for a speech-language pathologist, and I never heard of a medical SLP before until now. So we used to bring in we had that referral. So does St. Joseph's work in conjunction? Would they let you go out to a long-term care facility?
This is Greg. This is going to open a whole can of worms, but I'm going to go here with you because I think that this is really important to discuss it. So St. Joseph's Healthcare actually does have an extension into long-term care. It's a bit unusual for a hospital to have long-term beds, but we do. I used to, when I was first hired with St. Joseph's, service those beds. Typically, we would get a call. It wasn't, again, a blanket referral. We would go only if we were called to do certain service delivery. But for the most part, and just again, from working in healthcare transformation and different models and how programs shifted, the program that I was with did shift into Parkwood Institute main building. And the access to the speech-language pathologists that were part of St. Joseph's changed. And so I'm not sure how it is every province, but where I am in Ontario, we have we have speech-language pathologists that consult to long-term care,
Okay.
and they're typically brought in by, they have gone by different names, but home care, community care access teams, or something called the LIN, which are the health networks. So there's a lot of changes again in those systems, but I have to always be careful how I say this. I think we could do better. I know we could do better. I feel that, I feel it's a real challenge because the understanding of the discipline and what the discipline can do.
Mm-hmm.
I heard you describe you had part-time PT, part-time OT, and some rehab assistants, but no speech-language pathology.
None.
And you would probably have called and consulted that in.
Correct, yeah.
After we talk, of course, if you were doing that job now, you would make sure you advocated strongly for the services of a speech pathologist, because again, it's so invisible. I'm not sure where this will come up, but I'll talk about it a bit here. We really do understand the physical challenges that people have, so that if we can see an individual in a wheelchair or using a gait aid, we immediately know that we have to do something, to help that individual, because it's so visible. Yet, when we talk about cognitive communication or just communication issues, it seems uncomfortable for people to sort of service that in the same ways that we would service for physicality. And I'm always kind of on about, we talk about holistic medicine,
Mm-hmm.
and that's really important. I couldn't agree more. However, there's a lot of understanding of the physical body and the issues around helping people with mobility and accessibility through movement of the body. But the same is true of the mind, and the same is true of communication. And I just think that I'm almost famous for saying this, but we would not deny a curb cutout to come into our building. Yet, we do not have the same curb cutouts when it comes to helping support individuals who communicate in alternate ways, or who have challenges in communication.
Mm-hmm.
And I think until we get to this idea that holistic medicine is mind, body, spirit, and really mean that, and we fund it like that, and we get people who are quite vulnerable, who are not able to self-advocate, more access to people who can advocate for them or with them, it's just going to be continue to be challenged. So your questions about long-term care, and there are many individuals, I believe, who are there who just would benefit from optimization,
Definitely.
advocacy.
Definitely.
Yeah, and because they have, they might get swallowing services, and that might have been your experience too. They will call the speech pathologist for swallowing, which is really critical and important. But we need to call for communication and cognition too. And I think that that's really challenged. I think some of the best advocates, unfortunately, have been people who had loved ones who were having challenges and sort of needed the services. And when you have this lived experience, unfortunately, this sort of helps people to advocate for the roles of these disciplines that are working in what I call the invisible, and an extremely vulnerable population of people.
You see,
I think it's important.
Unfortunately, Penny, and you've also seen this yourself, that first when I started to work in long-term care, back then the homes were called homes for the aged. And as the years went by, there was a lot of changes in the target population. We were, admitting young adults, Alzheimer's, Parkinson's. So the whole target population changed. But unfortunately, you're so true. The long-term care needs specialties on site, like a full-time, even if a part-time SLP. You know what I mean? And so it's an ongoing challenge. Now,
there are there's a synergy too,
Yeah,
right?
definitely.
When teams work there, there's a synergy. So I always say that if I go to palliative care and I don't go maybe for several months, if I go once, I will be called back 3 more times because I've been able to help the individual. And it's been, oh, there's that service. We need that for this, this, and this. So when you have in long-term care, if you have professionals who are part of the team and are integrated into the team, it's just natural, the synergy of working like that. It doesn't have to be sort of a special request. And I think that really does unfortunately impoverish folks that could benefit from supports and advocacy.
Do you have, like, are you working under constraints in terms of, are you allotted X number of time per patient, or is it restricted in many ways?
Yeah, I'm really fortunate. I'm not. Maybe after this podcast, they'll come for me and they'll tell me that I have to, but I'm not. I guess I feel really fortunate, privileged in a way. In the system to the south of us, I know I have a lot of colleagues who have a certain number of visits they're permitted to have. That does happen in the home care system, where there's allotted a number of visits. You can advocate for more. But I have a lot more, I would say, professional autonomy, working as part of the medical team. Maybe that's why I also like it. I have an opportunity to decide what that treatment looks like and for how long. There are some constraints depending on the level of care that the patient requires, and also their potential. So I do run into some constraints with this, but I'm mostly able to decide the frequency of the treatment and the length of time I'm seeing them for. But usually what the pressures are other referrals coming and, sort of having to prioritize within the caseload itself. But after this many years of doing it, I think I'm pretty good at it. And I have to say, sometimes I take pride in my ability to do that. And I don't always like other people to tell me what a patient's potential is, because I feel like we don't know. And I think that there's been lots of evidence looking at, people with brain injury or people with stroke many, many, many years out, doing very well or making continued improvements. Where when I was in training, it was, sort of that first 3 to 6 months, and then they stretched out to a year, and this was your rehab potential. But in my experience, I just don't believe that to be true. The human spirit is the human spirit, and I don't think that anyone sort of maxes out. I think there are times to approach, and I do this a lot in practice, where I'm in for a bit working, I may step back for some other priorities, and then I'll go back and check. And I think it is something that speech-language pathologists who work with disorders of consciousness in particular, these are individuals who are, minimally responding, but you have to keep checking. And it's really hard to do that if you're not on staff. So if you're just consultative, going in and parachuting in and doing something and then leaving again. So I guess I'm fortunate that way, that I don't have to. Current state, I do get some pressure sometimes, to think about the frequency of the visits, and so I tend to try to respond to that before anyone can tell me. I like to make up my own mind. Yeah, in conjunction with the patient, of course.
I kind of had a question that spawned out of curiosity when we were talking earlier about kind of how different things are now because of COVID. I know that kind of in stuttering and in other areas, like, working on RTIC with kids, there's been a whole thing about masks and how they've kind of caused a barrier to that. And I'm just wondering, from like a different perspective from working in the medical setting, how do the masks and other COVID precautions kind of impact what you're doing, and things with like IAC and things like that? How much harder does it make it?
Yeah. Oh, you have some good questions, you guys. Okay. All right. So, yeah, that was a huge thing. I would think in the first and second waves, the speech pathologists where I'm working were very proactive in getting the clear masks because we recognized that there was going to be a large number of people who are hard of hearing, who would benefit from having that on the clinicians. The problem was that we just had the Health Canada approval piece to get in place, and it was a little slower than our pivot to virtual care, which is interesting because I thought it's pretty important we get these clear masks. So I think our group was really proactive in getting access to clear masks. It is a huge barrier. I think, in fact, I was counseling someone today about the loss of all of the nonverbal communication that happens when we mask 2/3 of the face. And we're now in a place where we have actually met people only with masks. And so that when they remove their masks, sometimes we're surprised by the way that they actually look because our brain, as amazing a system as it is, has filled in the information that was under the mask. So I think we're going to see in the next few years, it'd be my guess, that we're going to see a large number of children who may have some challenges with facial recognition cues, being able to read faces, being able to use their cues themselves, because we use certain things and then we get feedback about did that work or didn't work, and we adjust or we persist in doing it. Even within my own 4 children, they actually talk about other people at school using features that are in the top 1/3 of the face. So they'll say funny things at the dinner table like, oh, was that the Matt who has the unibrow? Was that the Matt who has the blue cap? Or is that the person that has, I don't know, dark eyebrows or whatever? Because they're using this information coming from the top of the face to identify, because they're sort of stripped of all of the extra cues. So I do think this causes people to be misunderstood as well, with, again, their cognitive communication abilities. So they are literally masked. And I think the article that Greg had sent out about masking is really interesting because these individuals are sort of literally masked in terms of their potential for just what their memory and attention skills look like, because we're not getting all of the clues and the cues from the face. So it goes both ways. Communication at its basis is communication, message in, message out, but there's this nonverbal communication piece that's really negatively affected by the masks. Mm-hmm. And so I don't know if that fully answers what you were thinking about with the question, but I was with someone else today, a different patient. She was walking for the first time. I was doing a joint session with her in physiotherapy, and she is aphonic, so she does not have a voice, and she was mouthing, but without the voice behind it. I said, I have to go get a clear mask for her, so we can see what she's doing here. So yeah, that's a really good question. I think we're going to learn a lot of things that were challenges for people around masking.
With with people who stutter that have taken the therapy, it is a challenge with still not only with the cloth mask, still with the clear mask, because of the breathing, because we do a lot of full breaths and everything, and so I find that is still restricted in many ways to taking a full breath, and plus all the steam and air associated. So it's mixed. You know what I mean? It's mixed.
It kind of becomes its own distraction.
It can be.
Fogging up, and something else you have to contend with. Yeah.
Like is there a number of speech-language pathologist students that, like, Katelyn can answer this as well, like, are attracted to the medical SLP area now? Is that changing? Or?
I'm trying to make it happen, Greg. I'm trying to bring everybody over to the other
It is.
side.
It is happening.
I have this,
It is happening. Oh, yes.
Is it working? So it's interesting. That's a really good question, because during the pandemic, I have tried to also rise to the challenge of getting people graduated. When everything closed, all the schools closed and the health units closed and all of these things closed, hospitals remained open. And so I took more students. I've taken 8 students since the beginning of the pandemic, and typically I'd have less than half of that, trying to get these students graduated, because I felt it's important. Obviously, I'm a slight bit biased about it, but often students will come and I always ask them, are you thinking about children or adults? And most of them would say that they're undecided, that they might be leaning more towards pediatrics and children. But my answer to that is always the same. Well, I am going to convert you. I am going to change you over to really seeing the benefits of working in the adult world and not having to hide your goals. I mean, what would that be like? I mean, you don't have children. When you work with children, you're often hiding the goals. You don't want them to know that, you're working on an R or you're working on a specific sound. With adults, it's such a partnership. And I love that. I love that I think I have, what we would be working on, and the adult patient says, no, I don't think that's important to me. I don't have a need for it. And then, so I do think a lot of them are coming out of their placements. I'm hoping, Katelyn's confirming it, to convert them over to considering this.
Yeah. The more I'm listening to you, Penny, I think you're a bad influence on Katelyn, because we need Katelyn here in Newfoundland, specializing in stuttering,
For sure, which is also great.
Yeah,
also great.
No, when just in a when an SLP says that he or she is a medical speech language pathologist, so do they sort of deal with the various areas that you pointed out earlier? So the reason why I'm asking that is that Newfoundland, just a few months ago, I was talking to an SLP here in Newfoundland, and they are not permitted. I'm not too sure if I got this right, to say that they have a specialty in stuttering. They have an interest in the area. Is that the same with?
That's correct.
Yeah. You know what I'm saying?
Yeah. Yeah, you're asking some great questions, you guys. Yes, and I sit on guidelines for the province of Ontario and Quebec in brain injury and in stroke. And this comes up a fair amount because to the south of us in the States, colleagues are permitted to have expertise and to identify themselves as experts in subject matter. So when I sit on guidelines, this often becomes a thing because they want to put my name down as an expert. And I say, I actually can't let you do that because I am not by my college permitted to call myself an expert. But I know that that's changing, and there is conversations happening with the college around identifying, because really, if we think about mentorship, you really want to be able to identify people that can mentor up and coming individuals. So having an expertise in stuttering or having expertise in brain injury, helps people to find their way to mentors and to the supports that they need as they're learning. Because it's not like you go to school, Katelyn can say, for 2 years and you learn everything you needed to know. You are really lifelong learning. And I think having some discussion, I think the college is doing this around expertise or designations could be helpful to how we train and how we mentor.
Mm-hmm.
And I would say, just to go back to your point and your worry that we might flip Katelyn over to medical speech pathology, I would say my guess is, in my experiences, we get spread very thinly. And maybe that's not a good thing, but it can be a good thing because it means you get to do lots of things. Variety is the spice of life for me. And my guess is you probably would find yourself being able to do some of all of that, and do where your passion lies. And particularly going back to home communities, I did that myself. I'm from a small northern community, and some of the very best training happens in a small community because things can happen. Things can be made to happen. So it's good to put out there in the world kind of what you love.
I don't know about you,
what
Penny.
you
I don't
want.
know,
Just
Katelyn.
as Greg is,
I don't know.
as
I
Greg
don't
is
know.
doing.
The medical setting
Yeah.
scares me just a little bit, as interesting as it is. I don't know that I could work in a hospital. But I'm on doing my placement this semester, and I'm doing like adult neuro, which is far from anything I ever saw myself working in, but I am really enjoying it. So that's cool. I don't know if I'd make it all the way to a hospital. Yeah. But there are a lot of people, more people in my program than I thought, interested in working as a medical SLP in hospitals specifically.
Mm-hmm.
Mm-hmm.
See, one thing about Katelyn is that she's also interested in the emotional component of stuttering, which unfortunately is very lacking. I mean, a lot of the SLPs are trained, like in terms of the actual physical component. There's some knowledge base with regards to the emotional component. But I think there needs to be more training, and Katelyn's interested in exploring that area. I'm curious with you, Jenny, like in terms of like the emotional component of your job. I mean, that I'm sure it's emotionally there's a lot of demands, but is there training on that side of it, with the medical speech-language pathologists?
Yeah, it's huge, right? I think I can't think of any, when I say disorder area, but any challenge, any communication challenge, an acquired language disorder where there isn't a huge component of adapting, adjusting, coping with that. I think for a lot of years we underappreciated that aspect of it. So I'm really pleased, Katelyn, that you have an interest in that, because I think sometimes it's harder to talk about it because it's more difficult if you don't have the lived experience yourself. I had the benefit of two instructors at Western who were teaching in stuttering and were stutterers. And I think that the importance of being instructed by lived experiences is so important to developing empathy and understanding and being able to, I guess, appreciate the emotional component. For me, I really would say I didn't appreciate as much as I do now the importance of peer and peer support. We talked about it as though it was a separate island of things that happened by some other agency that got people together and did that social work thing over there. And I would say about 12 years ago now, I started a program for people with concussion, so people with brain injury. And I was really doing it, to be perfectly honest, to address my wait lists, to see if I could get people grouped together to do some help on my wait list. But within the first year of running it, what kept coming back were patients saying, "Oh my gosh, I'm not alone. I didn't realize there were other people who have this. And it's so nice to come together somewhere where we actually just talk the first time about my brain injury. And then we actually don't talk about it too much after that, because we get to the business of being, in the world and just getting to the work of how, I'm going to, succeed with whatever my goals are. In this case, going back to school." but it's this unspoken thread that people get from peer support and being with others. And I think that this is really tremendous. And sometimes the peer support doesn't come from a large group. I do a lot more putting people together. So if I have patients who are really struggling at one point with augmentative communication, it's not uncommon for me to go and find a patient on a different unit and put individuals together so they can talk about this and I can listen and learn. I also run joint groups, often with social work, to do this because I recognize that I think it's all about communication, but there are many times where it's about a lot of other things that we have to unpack. And so joint sessions with social work or another discipline can really help. I think I feel fortunate again in medical speech-language pathology, you are in a building with a whole team of people who are hopefully like-minded, and we want people to have hope and to be holistically receiving their treatment. So it's a really good question about helping people with the emotional coming to, I don't know if the word is terms, or optimizing and dealing with that new reality. For some of the folks I see, this is they were not having communication challenges, then suddenly they are. And there's a lot of advocacy, education, counseling with families. But I think patients know themselves best. And when you put them together with other people who have lived experience in the same way, it's really powerful.
Listening to you, Penny, brings back a memory. This is a throwback Tuesday memory, because I remember when I worked for one of the homes as a social worker, we had a number of aphasic residents, and the loved ones of the aphasic residents were upset because we didn't have any specialty back then to communicate with the aphasic residents. So so myself and a family member and her daughter developed an aphasic group, and we actually managed to get $2,000, and we actually set up binders for each of the units for the nursing staff, and so we had 4 binders. We had one for just general symbols like pie, food, whatever. We also translated one binder into Greek, French, and Portuguese. So this these are the residents we had back then. Marion and Lynn and myself, we were so proud of ourselves, and we actually won an award that year for this aphasic program.
I'm not surprised. I'm not surprised. Like, that just sounds, that's just so grassroots, and just meeting the individuals where they are. I think that is tremendous. That is, I'm not surprised you would win an award. I think that is exactly the kinds of things we need to do, is, sort of build things as people need them.
So
and you probably had lots of interest.
We met weekly, and the nurse started to use the binders, and the home started asking, the other home started asking for binders. So I remember transferring to another home within long-term care, and they had their own set of binders. I was so proud of myself, But anyhow.
You create those things, then they start showing up at other places where you actually weren't working, where they use the materials. That's tremendous. That's very grassroots.
Well, Penny, not to hold you up more, but this has been great. Katelyn, do you have any more questions for?
I did have one more. It's my favorite question to ask any SLP, any practicing SLP or researcher, anybody that comes on really, and I think it's especially important to ask you since we've never had a medical SLP, but just for advice for any, young SLPs or SLP students or aspiring SLPs listening to this episode, any advice that you have for somebody interested in SLP, specifically in medical SLP?
Yeah. Okay. I would say get ready. Get ready. You need a strong mentor. I think having someone who is working in this field can help guide you towards some of the best aspects of it, and also the realistic ways that we're challenged every day. We're spread super thin, and we have to do a lot with very little. And people don't always understand us exactly as they would, when the physio comes down the hall. No one says, "What does this physio do?" Yet when I'm coming down the halls, sometimes the patient might say, "I'm not sure why I'm seeing the speech-language pathologist." So I think we need to be not afraid to step forward and to claim the space to advocate for these very vulnerable patients. I think that's something you need to know about yourself, is that you've got to be very sure-footed and be able to advocate for people who cannot advocate for themselves. And so it's a constant stepping forward into, I'm going to have to, step into this. I'm going to have to advocate for this patient. And so I guess that's a couple things. I would say that now more than ever, because of social media, the opportunities, different sites, apps on the internet, there are some really great resources. I don't get any kickbacks from anything I'm talking about, but there's one in particular called Med SLP Collective. And this is all medical speech-language pathologists who are part of a collective group. You have a membership, and I have joined that. It's just sometimes a really great place to get information and resources and to share. They have mentors built right into the Med SLP Collective. And I think we should always be championing the work of others who go before us. We always are standing on the shoulders of giants, and there are so many people in the Med SLP Collective who are serving as mentors to keep the collective meaningful and relevant, evidence-based and up-to-date on every disorder area, including stuttering and the motor speech. So there's lots of great resources there. I think you do need to literally be the voice for people who are voiceless. And you don't have the luxury of wait and see what happens. We're not going to wait and see. We're going to get on with it. We're going to help people. And I think that's really requires us to have confidence in speaking up and asking for what patients require at the most vulnerable times in their lives. I said, my husband's a paramedic, and I say all the time to him, he meets people on their worst days. And you need a gentle, confident hand when you do that.
Just to follow up on Katelyn's question, what advice do you have for other, for speech-language pathologists in general for self-care? I'm wondering, Jenny, how do you self-care? Take care of yourself, given your...
Yeah, that's such an important one. I think that you have to realize it's not all on you to fix these things. And if you can get into a partnership with your patient client to understand what is they need from me. Is this an advocacy piece? Is this a cheerleader? Is this you want to help me break down some steps to get to a goal? I think listening to the patient rather than having to come up with all the answers. We talked about this in class about motivational interviewing. And this is really a way of self-care, right? As we don't have to carry around all of the challenges. We have to figure out, I say, what can I be used for? How can I be useful to you? And I don't have to come with every single solution because in a lot of cases, patients sort of do know what they might need from you. The other self-care, I think surrounding yourself with other people who are positive can-do personalities, and, taking time to enjoy the wins. There's this thing called hedonic adaptation that we get into. I don't know if you have ever thought about this. We have a level of happiness and we get something good and it sort of bumps our happiness and we sort of bounce back down to our natural state of happiness. And things that really get us down, they don't keep us down for too long because we adapt and we sort of just move around in this space of, pretty stable happiness. And I think sometimes when we get wins, or something really awesome happens, we need to write it down and we need to keep it in front of ourselves and not adapt so much to that, and don't just take it for granted. I have a gratitude file that I keep in my drawer, and it's really thick now, and it's really patients and families and other team members who write cards or an email, and I print it and I put it in this gratitude folder. And then sometimes when I'm feeling like, oh, this is really hard, like, I don't know, during the pandemic in all the waves, I pull it out. I might take a look at it or just remind myself when I see it. There's a lot of wins that we have. I think pausing on them maybe a little bit now is important as part of self-care. So, yeah. And then you just need a few teenagers around you to be reminded, of the fact that we're not here just to sort of help ourselves. We're here to help other people. And I think that's kind of what the pandemic's taught us, right? Is we're all connected. We might be in different boats, but it is the same storm. And we know we need to be connected. So we should just reach out and ask for help when we need
Wonderful. Wonderful.
it. I should tell people that I came across a day in the life of a medical SLP on tactus therapy. And so if people are interested in going to tactus therapy, again, I'm getting no kickback for this, a day in the life of the acute care and the rehabilitation.
I saw one too
SLP,
online on TikTok. That was a day in the life of a pediatric SLP. They were doing like feeding and dysphagia stuff, which was really cool.
Isn't TikTok going to
I find some cool SLP stuff on there.
No, yep. Agreed.
Yep.
Instagram, I'm telling you, all of those things. This has been an episode of Some Stutter Law, Newfoundland and Labrador's first podcast about communication disorders. Some Stutter Law is hosted and produced by Greg O'Grady, Katelyn Mayo, Dr. Paul D. Decker, Luca Dinu, Emily Murphy, and Melanie Crane. Some Stutter Law is available on Anchor, Spotify, Google Podcasts Breaker, Apple Podcasts, Pocket Casts, Overcast, Castbox, Stitcher, and Radio Public. You can also check out our videos on the Some Stutter Law YouTube channel. To ask a question, send us a comment or a suggestion, or just to get in touch, find us online at www.somestutterlaw.ca, at Some Stutter Podcast on Instagram, or at Some Stutter Law Pod on Facebook. Thanks for listening.